The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
A shortage of family doctors, hospitals facing crisis workloads. Tonight, what role can private care play in Ontario's healthcare future? It's Wednesday, September 14th, and we'll explore that next on The Agenda. It's rarely the case that something that happens to the host of this program becomes fodder for an episode of The Agenda. But a few weeks ago, with my family doctor on vacation, I tried very unsuccessfully to find another doc to check out my aching knee. Because I struck out so many times, I ended up visiting 2 hospitals on 2 different days, 2 hours drive apart, getting 2 ultrasounds, 2 blood tests, and stressing the resources of a healthcare system already under too much stress, all because I couldn't get in to see a family doc. Danielle Martin is perhaps Ontario's best-known family doctor. She's also chair of family and community medicine at the U of T, and she joins us now to talk primary care. Great to see you again in person.
Great to see you too,
We've done
Steve.
this a few times on the line, but it's great to have guests back in here. Let's start with first principles. The family doctor is so important to the overall healthcare system because why?
Saves money, improves health, and improves equity. So there's very strong international evidence over many, many decades that health systems that are based on a solid foundation of primary care and family medicine produce better outcomes in terms of better health and are less costly. But for people, it's also important because we know that family medicine and primary care are where we catch things early. They're where we follow chronic disease and try to keep it under control so that we don't experience complications. And it's also the place where people develop a relationship with the health system. You know, I like to say that if when somebody asks me a favor, do you mind just taking this patient? I'm happy to do it, but I remind them that they're asking me to make a 40-year commitment because that's what it is. You know, it's a long relationship that we build over time, and it becomes your point of entry into other parts of the health system. So for each of us as individuals, it's critically important. And for the health system, there is no number of hospital beds that we can build and no number of emergency departments that we can open that will allow our health system to function in a normal way unless everybody has easy access to family medicine, which is exactly what you experienced.
Well,
Steve.
I'm drawing from, my inference that I'm drawing is when you say catch early, that's how you save money.
It's partly how you save money by catching early. You save money by preventing. You know, a simple conversation that leads somebody to quit smoking or to take a vitamin D supplement or to increase their physical activity can have huge prevention ramifications down the road. It's where we manage chronic illnesses and prevent them from getting bad. And so, you know, if we can manage a person's diabetes or their high blood pressure or their cholesterol in the family medicine environment, we can stop them from having a stroke. We can stop them from having a heart attack. So these are significant outcomes that are, of course, devastating to the person and to the family, but also extremely expensive to manage in the health system. And they put you in the place where you least want to be and the place where we all least want to be, which is in the hospital.
Right. 15 million people in this province. How many don't have a family doctor?
Almost 1.8 million people don't have a family doctor or are loosely attached. And another 1.7 million people have a family doctor who's age 65 or older.
Which means they're going to lose them soon.
I mean, you know, that's what the data would suggest. And we've all seen in the pandemic an acceleration of that. So about double the number of family doctors retired in the pandemic as compared to prior years. And so we're seeing an acceleration of that. We're seeing it, of course, all over the health system, not just among physicians, nurses, and other healthcare providers are retiring, are choosing new careers. It's been a time, right? And so we're feeling those ripple effects across the health system. And I'm very worried, Steve, that we are at a point of crisis in family medicine and primary care. And there is, it won't be possible to fix healthcare unless we fix this first.
This may be a dumb question, but it wouldn't be the first time I asked a dumb question, and that is, how is it that 1.8 million people in this province don't have a family doctor?
Yeah, it seems so simple, right? And it turns out it's one of those thorny problems where we say, okay, well, I guess we better train more family doctors. Then we train more family doctors, and it turns out they don't go and work in the places where we need them to work, or they don't practice the kind of family medicine we need them to practice. And then we say, okay, well, we should build teams. But it turns out actually that if you build teams, then you have to put in place an infrastructure around that, and the government's not funding those kinds of teams anymore. And so we keep kind of trying to move for the simple solution. And it turns out the complex problems require thoughtful, multifaceted solutions, and sometimes they take time.
So we can't just say that because some government 20 years ago failed to do X, Y, and Z, that's why we're in the pickle we're in.
No, because of course there's more to it than that. So yes, of course, we would be probably in better shape if we had been training more family doctors throughout. Yes, we would be in better shape if we had put teams across the province so that people aren't relying, as in your situation, on a single provider. So if that poor guy takes a holiday, his whole practice falls apart. I mean, it's not a tenable situation for him or for any of the patients he cares for. But I also think we have to acknowledge that we're in a situation of an aging population. And so that changes everything. The family physician workforce is aging. The patient population is also aging. People have many more chronic diseases. So I don't see in my practice anymore people coming in with, whatever, came to have you look at my toe. People come with 5 things. That's the, and very often now in the post-pandemic era, one of those things is a mental health concern. And so it's just getting more complex. The work is getting more difficult. And for those of us who chose this career, it's an honor and a privilege to do the work. But it would be easier to do if we were functioning in an environment where the system could support it.
Let's stipulate right here. Now, my situation doesn't amount to a hill of beans, as they say, but I remember when going through it, thinking to myself, I've lived in this province pretty much my whole life. English is my first language. I have some sense about how to navigate my way around the healthcare system. Not a fabulous sense, but some sense. And I remember thinking the whole time, if you're an immigrant, if English is your second language, if you've only been here for a couple of years rather than 60 plus years, what would you do?
Yes.
What's the answer to that? What would they do?
The answer is people go to the emergency department, and who can blame them? Or they go to walk-in clinics, and who can blame them? And I think those are stopgap measures. They exist in the system. We need them to exist in the system, but none of us thinks that that's where we should be getting our day-to-day care. And so, the answer for that person who is struggling to figure out how to navigate the system, they show up in the hospital or in the emergency department. I mean, as we all know, the role of the folks in the emergency department is to deal with the crisis at hand. They're not also, while you're here, going to make sure that you're up to date on your mammogram, or your tetanus shot is up to date, or have a conversation about the relative risks and benefits of having a PSA test. I mean, they're not going to do any of that stuff, and so we're not keeping you well in that circumstance. And the data do support what you've said, that people who are new Canadians, people who are living in poverty, in low-income neighborhoods, are even more likely to be unattached to a family doctor or a primary care team. And of course, those are the people who, on the basis of their social determinants, are the ones who most need it. Right. So we've got it all backwards, and we are in a situation where we're going to have to invest energy and also some money in fixing the situation so that we aren't funneling everybody towards the emergency department where things are at a breaking point.
Well, play that out for us if you would, because you said 1.8 million people don't have a family doc. So if, for example, they need to get some medical attention and they end up going down to their emergency department, if that situation gets replicated time and again at ERs all over this province, what's wrong with this picture?
Well, I mean, this is how we end up in a situation where we hear about emergency departments, hitting the breaking point, people waiting hours and hours for care. We also know that in that environment, you're much more likely to have staff burnout. You lose your staff, you have to close your emerge. That puts stress on the emerge down the road. And it's not a tenable situation. It's also just really bad care. It's not what any healthcare provider went to school to do, to try to deal with the kinds of things that should be handled in the community in an emergency.
And a patient doesn't want to wait 8 hours to see a doctor.
Who would?
Yeah.
And none of us wants to see an older person lying on a gurney on a stretcher, transferred in from long-term care. This is not how any of us wants it to work. But The issue is that the problem that hits the headlines is that overcrowded emergency department. And so the knee-jerk reaction is, well, we better put more money into emergency departments. We better build more hospital beds, rather than saying, well, how did all of these people end up here? And is it possible that we could have done something to prevent it?
Okay. You are nicely leading us to where we need to go now, which is we are where we are. So we got to make some decisions today that deal with the issues that you have described here. So what do we need to do today to try to make sure that 10 years from now, we still don't have 1.8 million people, or God forbid, even more, who don't have a family doc?
So the first thing we have to do is we have to build teams. We cannot be in a situation where most people are relying for their care on a single individual family physician or nurse practitioner or any kind of primary care provider. When you have a team, which should include, yes, a group of doctors so that everybody can take their summer vacation, or somebody falls sick or goes on maternity leave, their practice is taken care of, but also many other kinds of healthcare workers. In this era where mental health is at a crisis point in Canada, most of those teams need to include a social worker or a registered psychologist or another person who specializes in mental health, because otherwise what happens is I, as the family doctor, am spending my time doing counseling, which I can do, but actually a social worker would do a better job of it, and that would liberate me to deal with the medical issues that are coming in that only a family doctor can deal with. Similarly, pharmacists, nurses, physician assistants. There's very interesting work happening in the US with a new job called scribes. These are people who will enter all of the information into the computer so that I can be looking at you instead of looking at my screen, entering stuff into it, and allows me to be more efficient and move more quickly and see more patients per day. Community health workers who go out into the neighborhood and get to know who lives in the area, what do families need, what are the health needs that are unmet.
These are all on the same team.
Yeah, I mean, I'm not saying you need every single one of those people on every single corner, but you can build a network in a neighborhood or in a community where each of those team members is doing the thing that they are best suited to do. And then you don't end up in a situation where you're relying on the most expensive providers, doctors and nurses, to do everything. And then, yes, of course, we need to train family physicians, we need to train nurse practitioners, we need to compensate them in ways that are consistent with the kind of care that we want them to provide. We need to support them in neighborhoods. But the very first thing we need to do is get out of the doctor-centric model and move to more of a team-based approach. That's what's going to allow you to be able to get your knee taken care of in the moment where it's aching and your family doc's on vacation.
And well, as it happens, I do have a family doc who is on his own and always has been, and I guess kind of likes it that way. What do we say to the presumably hundreds of family doctors in this province who are solo and want to stay solo?
Yeah, so I mean, I think that's a difficult conversation, right? One of the things we can say is, let us offer you coverage. I don't think anybody's going to turn that down, so that they know that their practice is taken care of when they go away. We've seen this advent now of virtual care in the pandemic, huge amounts of healthcare now in the province of Ontario being done virtually, probably in family medicine somewhere around 40% of visits occurring by video or mostly by telephone. And that can be really good for patients. I mean, a lot of my patients love it. They don't have to come in. It's just something that can be dealt with a conversation. Not everything. Not everything can be dealt with that way.
But some things.
But some things can be, and it's a less of a waste of time. It's also helpful for people who have jobs that make it hard for them to take a half a day off to come and see their doctor. So there's an equity dimension there too. A team can, if you construct it right, we can be offering those solo practice folks supports that will help them take better care of their patients. I'm not saying we all got to move into their office, but we can connect them with resources and services that will help them to serve their patient population better. And I think almost all of them would like to be able to do that.
I get this notion of you got to create teams, but how do you even begin to put something like that together?
Well, we have some teams in the province. About a third of Ontarians, like 30% or so, are taken care of in some kind of team-based model. And that includes a wide range, something called a family health team, there's a community health center, there's a nurse practitioner-led clinic, there's an Aboriginal Health Access Center, there's millions of different flavors of teams, but we've got them. And so one of the things that we can do is begin to just kind of extend those out. There's also a new kind of collaboration occurring that really took off in the pandemic called OHTs, Ontario Health Teams, which are sort of loose associations of hospitals and family docs and social service agencies in a neighborhood. So like a lot of this is about taking the resources we've already got in the system and networking people together. I mean, if you can imagine, Steve, that there are many parts of the province where until very recently, the hospital had no idea who the family docs were in the neighborhood, had no way of reaching them or reaching out to them. So a pandemic hits, you want to get personal protective equipment to the front lines, you don't even know who to call. Where the mental health agencies never met with the hospitals and the community health centers never met with each other or never met with the family health teams. Like in a neighborhood, we're all taking care of the same people, but no one was talking to one another. So a lot of the work that has to be done, they're not easy fixes. It's about building relationships between the different groups that are taking care of people in a community.
Let me ask you about money.
Yeah.
We're spending $75 billion a year in the province of Ontario this year on healthcare, this fiscal year. That feels like, I don't know, but it feels like a big number. Feels like it ought to be enough. Is it enough?
Well, we're not spending it right. So I hesitate to say that there's no place where investment will be needed. But probably one of the reasons why there is going to be a requirement for investment is because we're not so great at uninvesting in things. Most of that $75 billion is being channeled into hospitals and doctors. So, you know, this is the core of Canadian Medicare. We said we were going to pay for doctors and hospitals for everybody. That's mostly what we pay for. But times have changed since the 1960s. We're now in a universe where people are older, they have many chronic diseases, the care that they want and need is in their homes and in their communities and neighborhoods. So we've got to now invest in those parts of the health system, something that we've been saying for decades. Now in this, dare I call it the post-pandemic era, the coming out of the pandemic era, it's critical. There is no way that we're going to get through this recovery without investing some money, yes, into primary care and communities.
Is it a problem in Ontario that there are still a lot of people who go to med school who don't want to be family docs, they want to be specialists? Yeah,
so it's an interesting thing, and we have seen a decline in the number of graduating medical students over the last number of years in Canada and in Ontario who choose family medicine as their first choice. And so some of that has to do with who we're bringing in to medical school. Some of it has to do with what we call the hidden curriculum, or the messages that we send to people, subtle messages about specialties or specialist care being more fancy and important than primary care, more glamorous, certainly in some, not all cases, better compensated. But, you know, some of it is also that we're in a situation in the health system where students see what they would be coming out into. And so, you know, part of it is if we fix what it feels like in primary care, when students rotate through their family medicine rotations in the community, it's going to look like a really exciting and wonderful place to work. When they see a bunch of burnt out people who are not sure whether they would choose this career again, it's not a great advertisement for the discipline. The other thing that we're seeing happening that's, I think, really important, Steve, is a larger number of people who are being trained as family physicians. We train a lot of them at University of Toronto, who then graduate and decide, rather than practicing general comprehensive family medicine, that they would prefer to be in an area of focused practice. So they're a family doc, but they only work Emerge, or they're a family doc, but they only do sports medicine, or they're a family doc and they only do psychotherapy or palliative care or what have you. And these are important services that our communities need, but it just means that we're training people. We think we're counting family doctors, cranking them out off the assembly line, but we're not getting a comprehensive family doctor at the end of it. And so we probably need to be exploring more why people are making those career choices and seeing whether we can make it appealing to those people to do a little of both. You know, for many, many years, I delivered babies as part of my family medicine practice. I did that, you know, Wednesday night was my night on call. The rest of the week, I took care of my general patients in my practice. So just thinking about how do we make it possible in people's lives to both carry a comprehensive family practice panel and have an area of interest where they're contributing, as a person with enhanced skills.
Okay, in our last minute here, the big political question. Governments clearly understand what's required. What confidence do you have that it's going to happen?
I think we're going to have to push hard for it. Every one of those 1.8 million people who are loosely or unattached entirely from primary care needs to make a phone call to their MPP, needs to ask their local hospital, what are you doing to entice family doctors to come and work in the region? All those of us who are lucky enough to have a family doctor need to help to raise this issue in the public consciousness, because we all know that our political decision makers respond to pressure from us as citizens and voters and residents of this province. And that's our job, is to tell them what matters to us. And if we keep building hospitals and long-term care facilities and failing to invest in primary care, we're going to keep getting the same result.
It's like that commercial. Pay me now or you can pay me later.
Correct.
It's cheaper now.
It certainly is, and a lot less painful.
That's Dr. Danielle Martin, family doctor, chair of family and community medicine at the U of T. Dr. Martin, always a joy to have you here on our program. Thank you.
Thanks, Steve.
Did you catch Ontario Health Minister Sylvia Jones's comments last month? When asked how she intended to deal with the myriad problems affecting the province's healthcare system, the minister said, quote, "After decades of inaction, we can no longer stand by and support a status quo that cannot respond to the current challenges the sector is facing." What exactly does that mean? No one's exactly sure, but it probably means allowing more private players to offer publicly insured services. And if so, is there anything wrong with that? Let's find out as we welcome, in Kingston, Ontario, former Federal Health Minister Dr. Jane Philpott, now Professor and Dean of the Faculty of Health Sciences at Queen's University. In Hamilton, Ontario, Dr. Bill Oravan, Vice Dean, Clinical Services and Commercial Enterprises in the Faculty of Health Sciences at McMaster University. And in Oshawa, Ontario, there's Natalie Mehra, who is the head of the Ontario Health Coalition. And we are delighted to welcome you three back to our airwaves. And as we occasionally have to do from time to time here, let me at the outset say, in the interest of full disclosure, my wife is a health policy analyst. She deals with these issues all the time. And we put that out there in the interest of edification or whatever. Okay, Dr. Oravan, let's get you in here first. If the Ontario government is, in fact, looking to get more private delivery of publicly insured services, tell us what that actually means. What does that look like?
Sure. So I think that's absolutely the right thing to do. We've been discussing this now for a number of years. I've watched the healthcare system deteriorate. I've been in this healthcare system now for 4 decades. I've seen successive deterioration. I think there's no question that the pandemic has shone a light on this, showed the deficiencies in the system. But even before that, we were operating in a situation where most public hospitals were at or above capacity. And we simply need to add real capacity to the system in order to keep up and in order to accommodate the growth in population, the aging that we'll see. I think if one of the best solutions in this is to allow more private operations to provide physical facilities and to attract back to the profession a large number of healthcare workers who have left the profession earlier than they planned because of the stresses induced. And now we're finding that even though we have millions of delayed interventions or investigations, we can't keep up with the new problems that we're facing, let alone address that. We need to have additional capacity. The private sector can provide it. We can pay for it out of the public system. You can present your OHIP card showing that you're an insured person. That OHIP card pays the doctor's fee. There was some negotiation that needs to be done around funding the actual operating costs of those facilities, but it can be done, as has been shown in a lot of jurisdictions elections in the world. And as Mr. Legault, for instance, in the ongoing election campaign in Quebec, has promised to build up to 12 privately owned, privately operated facilities.
I'm going to come back to that in a second. Okay, let me stop you there because you've put your position on the record very well. Dr. Philpott, let me get you in here and say, if the Ontario government decides that it wants to have more private players providing publicly insured services, what would be your view of that?
So, Steve, you know I'm going to slightly frustrate you here because I think that we have to have a nuanced response to this question. I think the question itself can be a bit of a distraction, and we need to define some terms first in terms of what we're talking about when we talk about private healthcare, whether it is private delivery of healthcare or private payment of healthcare. And then, of course, even within private delivery, you've got private for-profit and private not-for-profit. So there's a tremendous amount of misunderstanding about what terminology we're using, and I think it's really important to be able to have those conversations. I've told you before, I am not fundamentally opposed to private delivery of healthcare because, of course, I'm a family doctor, and most family doctors in the province, if not, and as well as the country, are private practitioners. In fact, they're private for-profit practitioners, but they have obligations to ensure that for medically necessary care, that has to always be publicly funded, and that people can't access care based on private pay for medically necessary services. It has to always be done on the basis of medical needs. So I think that it is unhelpful for us to be ideologically entirely opposed to private delivery of care, or ideologically in favor that that is going to solve all our problems. I think it is neither the whole solution. There are a whole range of other really important solutions, nor is it something that we absolutely shouldn't be open to discussing.
Okay, appreciate your nuanced take on that. And Natalie Mayer, let's go to you and say, same question. Again, if the Ontario government, in its wisdom, decides it wants to have private players provide more publicly funded services, what would be your view of that?
Well, I think we have to be clear that they are actually already doing it, first off. And second off, I think it's pretty clear what we're talking about. The new thing is that the government wants to hand over money to private for-profit clinics that operate sort of as mini hospitals to do surgeries and diagnostics. They announced that, I think, quite clearly in August. And according to the Financial Accountability Office of Ontario, they actually are already doing it in the last quarter of last year. So the period ending April 1st, they doubled the quarterly payments to the private clinics to increase their surgeries and diagnostics. So that is the for-profit privatization of services that were heretofore offered in our local public hospitals. It's quite different than a family doctor who operates in a group or on their own. These are for-profit companies that run these clinics. And I think the other thing that has to be clear is that we have called all of the for-profit clinics. I mean, they have moved in some parts of Canada more than others to take over public hospital services. And each time we've called them, and we've called them multiple times, we've caught the majority of them, not a small minority, but the majority of them violating the Canada Health Act and charging patients outright for surgeries and diagnostics, as well as selling a whole raft of additional add-ons, medically unnecessary services that they charge money for, because that's how they maximize their profits.
So can I just understand, Natalie?
And they bill patients on top. Sorry.
Can I just understand? So your prime objection to going further down this path is the notion that patients will have to pay out of their own pockets in order to avail themselves of these services. Have I got that right?
I think the biggest fear is that we will not be able to preserve single-tier public Medicare in this province or this country if the Ford government continues with its path of privatizing our hospitals. But there are other issues too. For example, quality of care. I mean, we just had a horrific expose of what has happened in for-profit long-term care in this province and across Canada. There are serious quality issues in the private clinics. In addition, we have the most severe staffing shortages, really truly unprecedented, that we've ever seen. We can't actually have MRI techs and CT techs, nurses, et cetera, taken out of our local public hospitals to serve only the lightest care, easiest care, profitable patients in the for-profit clinics, leaving the heavier care patients behind with less funding and less staff to provide for them.
Okay,
But
let me stop you
we
there.
have all kinds of unused capacity in our public hospitals.
Okay, let me stop you there, Natalie, because
sorry.
you've made 3 or 4 points here that I want to give the other two a chance to comment on. Okay, Dr. Orvan, you've heard about concerns about preserving the single tier, the quality of care, patients having to go into their pockets to pay extra money, staffing shortages. Are all these legitimate concerns with more private players, even if they're providing publicly funded services?
And there are concerns, but I think they can be easily managed within a private system, just as they are, or as we've tried to do for years within the public system. I mean, the reason so many people took early retirement and the reason we're having such a huge human resource problem is that people were stressed beyond belief and wanted to leave the public system simply because of those stresses. The ministers have said, both the previous minister and even the current minister, that what we should be doing is provide the right care at the right time in the right place. And that means that low acuity procedures that can be done in a private clinic, expand the facilities, the physical facilities, and the availability of staff should be moved out of public hospitals. There's no sense. For instance, here in Hamilton, where I work, our major cancer hospital has over 50% of its surgical volume is based on benign orthopedics. Total joint arthroplasty is not something that should be done in a major public hospital. It could easily be done in a freestanding, purpose-built, purpose-operated, private or jointly private and public facility. So that's where we're not interested in depriving public hospitals of anything. What we are interested in doing is improving the care for the patient. We've talked in this country about patient-centered healthcare for decades, and it's never happened because we worry about what impact it will have, probably none actually, on public hospitals, what impact it will have on the single-tier system, probably none. We're talking about public funding of private provision. All doctors in Ontario are private providers. We are not employees of the government. We are paid by public funds, just as we're proposing these private hospitals would be paid. We've had private hospitals in Ontario for decades. Schuldeis is one. There are several others that were put out of business many years ago, but some have continued to thrive. I ran one of them, actually, the Don Mills Surgical Center, for a number of years in the early part of this century. We provided quality care. We were remunerated by the public system, and patients did not have to pay out of their pocket for anything other than what they would have to pay if they were in a public hospital.
Okay, let me get Dr. Philpott in here. You've heard some of the concerns that Natalie's put on the record. Let me get you to address those if you would.
Well, I think the anxieties or concerns that Natalie raises are absolutely legitimate and things that we need to think about, and this is an important conversation to have. Human resources is our most significant rate-limiting step now. In addition to a few other things that I won't go down the road of in terms of the strength of our primary care system. But so we do need to make sure human resources are available for medically necessary care. And I think when you look at the potential for barriers to be put in place that will allow people to jump the queue by privately paying for publicly funded services, that is one of the most obvious concerns that we have. Will people flee publicly funded systems to be able to go to privately funded systems? So that's absolutely a reasonable thing to put on the table for discussion, and that's one of the reasons why public pay for medically necessary care is such an important topic. Having said that, there are all kinds of really important parts of our health system that are not publicly funded because of the way that the Canada Health Act was established. So it was written now, its 1984 version decades ago. Its roots are more than half a century ago, and it was done at a time when most care was delivered in hospitals and most of it was done by physicians. Now, all kinds of things that physicians previously did can be done as well or better by other parts of the health system, and much of healthcare that was previously delivered in hospitals is now being done in clinics. So that has totally changed the face of what healthcare looks like. We do need to modernize and update the Canada Health Act. And where I'm really concerned is about some of the most important parts of our system, like mental health care, like home care, like primary care, that are not protected by the Canada Health Act. And that's where we often are most at risk of being able to see that there's not sufficient public support, and where people actually have a barrier to accessing care if they don't happen to have private health insurance or the personal ability to be able to pay for those really important parts of their health care.
All right, Natalie, let me ask you what I hope is a logical follow-up here, which is that certainly because of COVID, there have been additional stresses on the healthcare system that are really profound. I mean, we've heard about the diagnostics backlog that could take more than $1 billion to resolve. We've heard about canceled surgeries and tests that people are waiting longer and longer for. Question is the Ontario government capable of increasing the volume of publicly funded services provided to patients if they don't get more private players into the system? What's your view?
Of course they are. I mean, every large hospital, the last audit that the provincial auditor did found that every large hospital in Ontario has operating rooms that are closed for days or weeks or months at a time every year, or even permanently, because they didn't have enough funding to run them. This is pre-COVID. That continues, and now we have these very severe staffing shortages in public hospitals, to the point where at this point, I was just talking with the chair of the Hospital Professionals Division at OPSU, the union that represents most of the health professionals in hospitals across the province. And she was telling me that we have MRI machines that are closing down overnight in our public hospitals because they can't get MRI techs. So you tell me, where is the staff going to come from to staff new private clinics that are being funded? They get facility fees and physician fees on top of the OHIP billing. And the evidence is that the majority of them extra bill patients on top, significant amounts. In fact, the majority of them violate the Canada Health Act and charge patients for their surgeries and diagnostics illegally. Many of them actually double dip, billing both OHIP and the patient as well for their surgeries and diagnostics. That's a higher cost, not a lower cost, certainly to the patients. And it imperils single-tier Medicare, and most of these people, of course, are seniors who are patients going to these clinics. So they pull the staff then, the existing MRI techs, out of your local hospital. The MRIs have to reduce their hours in your local public hospital, and the only patients that they can serve in the private clinics are the ones that can walk in and walk out. They're fast. They want the profitable patients, right? The easy patients, not people who are, like Shouldice will not take people who have diabetes and comorbidities, who are overweight. You have to lose weight if they'll do the surgery there for you.
Okay, let me get Dr. Orvan to speak to this then. Dr. Orvan, you've heard the allegation that in order to staff these new private players, you're basically going to pillage staff from the existing public system. Yes or no?
No, that's not true at all. As a matter of fact, we all know how many, particularly nurses have left the public system. They've left the public system because they don't want to deal with high acuity issues. They don't want to be put by mandatory redeployment in circumstances where they don't feel competent to look after patients. They don't want to work shifts. They want a different environment. We can provide that in the private sector with low acuity patients. There's no reason in the world why we should be doing low acuity surgeries or medical interventions in a high intensity public hospital where you have to maintain an ICU, maintain resuscitation teams and all of that. This can be done less expensively in a private institution, and public hospitals should do what they are best at doing, which is looking after the very sick and moving them through the system in a safe way.
Can I just understand? Okay, can I just understand? You just said you could be done less expensively than in a public system. How so?
Probably there are union agreements with public hospitals that require certain staffing issues that could be changed. We could reasonably use purpose-trained individuals to deliver care without having to do that with the registered nurses, for instance. So there are ways that we can in private practice where significant business decisions can be made that can lower the cost for these low complexity cases. It's very viable, and they do it in every other country in the world.
Okay, let me get Dr. Philpott on that. Do we have any reason to believe, Dr. Philpott, that if we had more private players offering publicly insured services, that there would be a flight from the public system to the private system of personnel?
I think it's a legitimate concern. I do think that, so I hear really smart points from both of my colleagues here who are on the call, and I think they need to both be open to kind of coming together and hearing each other to the extent possible, because, you know, Bill is absolutely right. There are all kinds of things that can be done more affordably in private clinics, and I use the family doctor's office as an example. You know, you can provide care for an entire year for a person in a good interdisciplinary primary care clinic for the same price of one emergency room visit. So there's a really obvious example. We need to make sure that we've got great outpatient, community-based facilities that are providing good, comprehensive, accessible care to our communities. That is a more affordable way of delivering care in many cases than having people to go to a hospital, and there's a good example of that. But, you know, the kinds of things that Natalie raises are also of a very legitimate concern in terms of the flight risk of staff. But, you know, where I think we need to make sure we're identifying the correct problem, she discussed that in light of the concept of people having additional add-on fees that they are being asked to pay in order to access those medically necessary services. That's where we want to run into problems. That's not because the care is being delivered privately. That's because people are violating the Federal Canada Health Act and putting those accessory fees or the extra billing fees that actually are a barrier to access to care. That's the federal government's responsibility to be able to identify that information, to make sure that provinces are not allowing that to happen, and then actually taking the money back from provinces to the extent that they have violated the principles of the Canada Health Act. So, you know, I think a serious crackdown from the federal minister to say this is not allowable, and if you are allowing this in your system, accessory fees or extra billing, that in fact we're going to pull that back from you, because nobody should be limited in their access to medically necessary care on the basis of their ability to pay an extra fee.
Just out of curiosity, when you were the federal health minister, how much of that was going on, and how much cracking down did you feel you had to do?
I was the first federal health minister to crack down in about 40 years. I sent a bill to both Quebec and British Columbia in the order of about $10 million each in each case, because we were able to get evidence of extra billing and user fees. Both of those provinces have, well, I'm not as intimately involved with it as I am, but we got the message across, and they changed some of the plans that they were working on and made sure that, well, as Natalie knows, there are still violations taking place. But again, this is where, you know, both the feds and the provinces have to agree, though. That is the fundamental foundation of our single-tiered system. It is not a perfect system, as I've alluded to already, but there's where the responsibility lies.
Okay, let's, in case the three of you are curious as to what the Canadian public thinks about all this, we're going to tell you right now, because Angus Reid was just in the field, and they did a survey, and it came out just the other day. And Sheldon, maybe you could bring this graphic up, and we'll share these numbers with everybody. Here we go. 61% of Canadians say healthcare is poor or terrible in this country. 61%. Half of Canadians surveyed reject the idea of more private care. 57% of Ontarians reject the idea of more private care, so a little above the national average. And about a third of Canadians say more private care would improve the system. Natalie, let me start with you. What do you infer from those numbers?
Well, I mean, it depends on how you ask the question, of course, as to how people answer. But I think the other thing is that we're talking about for-profit ownership of clinics and hospitals. And when you turn over the ownership of our public not-for-profit hospital services, the evidence is that they violate the Canada Health Act and they charge patients. If you ask the question of people, do you want to have to pay for OHIP and pay on top for private services, which is what the private clinics do, the vast majority of people would say absolutely not. And in fact, if people knew what the charges were, which are, for in BC right now, for a shoulder surgery in a private clinic, they're literally charging the patient 10 times the cost that the surgeon is paid in the public system.
What if you ask the question a different way? What if you ask the question a different way? What if you ask people, would you be prepared to voluntarily pay more if you knew you could cut your wait time in half? Any clue about what the survey would return?
If you were actually to fund the public hospitals, Ontario, for example, funds our hospitals at the lowest rate in the country. I was listening when Dr. Oravan was speaking, and I was thinking, have we really tried? We have not. In fact, we have chosen in this province, the governments in this province have chosen to fund our hospitals at the lowest rate in the country as a purposeful policy to downsize the public hospitals. We have the fewest hospital beds left per capita of any province in Canada. Canada as a whole has the fewest hospital beds left of virtually any OECD nation. We have downsized our public hospitals beyond all reason and beyond all evidence.
Okay, let me get Dr. Oravan back in here.
Them again.
Dr. Oravan,
fund the public system.
hang on a sec. Okay, I want to get Dr. Oravan on those numbers because Dr. Oravan, those numbers suggest to me that the majority of people agree with you that our system is not nearly as good as we think it is, but they don't seem to be embracing your notion of more private players in order to improve it. What would you say to those skeptics to get them on board?
Yeah, so what I would say to begin with is that, the total amount of money spent on healthcare in Canada in 2021 was about $310 billion. The other panelists here have identified some areas where a few dollars were spent inappropriately. That should not be allowed, and it should be dealt with. The Commonwealth Fund looked at 11 healthcare systems in developed countries, and on quality basis, Canada was 10th. Out of 11. The only one worse was the United States, and we know the problems that they have there. So there's no question that they have had the governments of Canada, of Ontario's provinces, and the government of Canada have had lots of time to address these issues, and they haven't. The number one performing healthcare system in the world, according to the Commonwealth Fund, is France. 27% of their hospitals are private hospitals, and they operate within the statutory arrangements in France and are paid the same way the public system is paid. 27% private. They have the best. We have number 10 out of 11. So no wonder people are upset. And it goes back to what Dr. Philpott was talking about. When you say private care, how do you ask the question? What does it really mean? Are you having to pay out of pocket? And the clear answer to that, based on international experience, is no, it doesn't have to be that way at all. We can do this in a more diverse system, cheaper and better.
Well, let me ask Dr. Philpott about something that's happening right next door to this province, and that is, I think it was alluded to earlier, the province of Quebec has announced during the course of the current election campaign that it wants to create 2 privately owned and operated urgent care centers with a promise, if the government's reelected, of more coming down the road, all within the current Quebec Medicare system. Dr. Philpott, any issues with that?
Well, as I indicated to you earlier, it's not how the delivery happens, it's who pays that is the important question. So there are all kinds of fantastic family medicine clinics, primary care clinics, all across this province, all across the country that are private organizations where the doctors earn their income from that. So they are there by definition private for profit, but they make sure, as long as you are not making people pay an extra amount for publicly insured services, you can deliver high quality, privately delivered care. But, again, I just want to reiterate the questions that have come up on that Angus Reid survey that you raised. One of the best answers of all, it wasn't one of the ones that you highlighted, but almost 20% of people said they didn't know. They weren't sure. poor Canadian public. They are being ripped apart in this philosophical debate. We need to stop having this specific debate and talk about how we're going to improve our healthcare system. There are all kinds of other ways. This is a legitimate conversation, but we need to be talking about all of the other ways that health systems need to be improved by training a stronger health workforce, by increasing access to interdisciplinary primary care across the country, to be able to do the things that cost less but get more value for money. And so, I'm sure that people will continue this debate, but it is weaponized, this particular debate, often for political reasons, as you've indicated. It comes up in election campaigns and people use it as a scare tactic. Let's have a civilized conversation. Let's recognize that there is a role for private delivery. There is absolutely a necessity for us to protect the Canada Health Act, which is the foundation of our publicly funded healthcare system.
Okay, well, let me ask Natalie. And Natalie, I hope you won't think this is a smart aleck question, but I do want to circle back to something that Dr. Oravan said earlier, which is that oftentimes the private sector can provide services, publicly funded, more cheaply because, for example, they don't work in unionized environments. And your organization, no secret there, very much believes in a unionized environment. You support people being allowed to organize into unions and have that representation when they're in the workplace. Is that one of the reasons why you're opposed to an increasing role for the private sector in medicine, because they tend not to be unionized workplaces?
No, and actually, that really isn't the case. If you look at for-profit long-term care, a lot of them are unionized. For-profit home care, there's some unionization, et cetera. The real issue is the impact on patients. We have one mandate and one mandate only, and that is to protect the public interest in healthcare and to protect access to healthcare under the principles of the Canada Health Act. The issue with handing over hospital services, which is what we were talking about, to for-profit clinics, is that it risks that fundamental principle that you would be able to access healthcare based on your medical need and not based on how wealthy you are.
Okay, fair enough.
In other sectors, like in long-term care, for example, we have seen now for 20 years, we have fought 25 years, we've fought even just to get annual unannounced inspections of long-term care homes. The industry, particularly the for-profits, have lobbied against us in that. And actually, the inspections were stopped in 2018, and comprehensive inspections of all long-term care homes in Ontario have never come back again, even after, by the last publicly reported figure, 4,700 residents died of COVID, not counting the ones who died of starvation, in dehydration, in absolute squalor.
No, I think we're all well aware of these situations. Natalie, you're going to forgive me. I got to jump in here because we're down to our last few minutes, and I want to make sure that I give each of you about a minute. Watch the clock, everybody. About a minute in order to respond to Sylvia Jones's comment. She says the status quo isn't satisfactory anymore. It's not getting the job done. In our last couple of minutes here, Dr. Oravan, you first. Give the health minister some advice on what she should do. If the status quo is no good, what's her next move?
Well, I would say that you're quite right. We've had this issue discussed now for decades. The Canada Health Act, 1980s edition. Maybe it needs to be updated and expanded to allow and include more private provision.
But that's nothing that Ontario Health Minister can do. That's a federal act. What does Sylvia Jones have to do?
But I think she should take seriously her own admonition, the right care at the right time in the right place. And there's no reason at all that low acuity surgical and medical procedures should be done in a complex acute care center where there's transplantation, cardiac surgery, cancer surgery. We should make room for those in the public system and take out of the public system what doesn't need to be supported by all of the accoutrements
I'm going to stop you there.
Sick patients.
Gotcha. I've got to stop you there. Make sure we stay on time here. Dr. Philpott, advice to the current Health Minister of Ontario.
So I heartily agree that the status quo is unacceptable. This is upwards of 40 to 50% of most provincial budgets. We all have to do better in this country so that one of these days the Commonwealth Fund report will say that we're doing better. biggest piece of advice I would give to Minister Jones is that I think every person in Ontario should have timely access to an interdisciplinary primary care team. Through our Ontario health teams, it should be as if you are moving to another community and you are looking for a public school. You will never have to wonder if your kid can go to public school. But right now in Ontario, when you move to another town, you have a very serious concern as to whether you're going to be able to find a family doctor or a primary care team that will see you. I think for a very reasonable amount of money, we can actually save dollars, provide better care, treat people up front, and make sure that we use all of our fantastic health workers in the best possible way.
Last 30 seconds to Natalie Mehra.
There's no question that the status quo in terms of the delivery of healthcare is broken. I mean, we have emergency departments closing across the province. We have a severe staffing shortage. I think the most urgent thing for this minister to do is to actually attract back the staff who have left, attract back the retired staff who have left, offer the incentives, get rid of Bill 124, actually deal with the workload conditions that the staff are concerned about, to get them back into our public hospitals and build capacity within the public system to provide the care that Ontarians need. I also agree with Dr. Philpott's urgency around improved primary care, which is actually what the Commonwealth report focused on as a problem for us, not hospitals at all, but actually access to primary care, which needs fundamental reform.
Okay, I'm going to stop you there. We're going to stop you there. That's our time. We are always delighted to provide free advice to the Ontario Minister of Health, and we have plenty of it from Dr. Bill Orvan, Natalie Mehra, and Dr. Jane Philpott. My thanks to the three of you for a very good and civilized debate here on TVO tonight. Thank you.
Thank you.
Thanks for having us.
Thanks.
Thank you.
And that is the agenda for Wednesday, September 14th, 2022. Tomorrow, we take a hard look at the very public side of the opioid crisis gripping parts of this province, particularly in the north. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.